Hello. Back pain is something that probably all of us will suffer from at some time in our lives. Every year in Britain, a staggering 40 million working days are lost because people are off work with back and joint problems of one sort or another. In this programme, we'll look at some of the common causes of back pain and what we can do about them. We'll also be talking about the serious causes like slipped discs, as well as the medically less serious but often aggravating and persistent back pains that can interfere so much with our daily lives. And we'll see a number of different specialists using different approaches to back pain relief, like physiotherapy, osteopathy, and the Alexander technique. We'll also look at the psychology of back pain and the value of exercise. And to guide us through the programme, I'm joined in the studio by Dr. Paul Stillman.
Hello.
Paul, let's start by finding out why people get back pain. What are the common causes?
Well, back pain isn't a medical diagnosis. Having the pain doesn't tell us what's wrong, only that something is. Fortunately, the great majority of people with backache have what are called functional disorders. These are caused by either minor injuries, bad posture, or sometimes just the general stresses and strains that we put on our backs in everyday life.
Why are they called functional disorders?
Well, because they're problems of the function of the back and they're not caused by any permanent damage or disease. In other cases, which we call the organic disorders, the problem then lies in some more permanent change, often as damage to the structure of the back is in arthritis, for example. In the back, arthritis obviously causes pain, and I hope that much of the practical advice we'll be giving in this programme will be useful to arthritis sufferers.
For more detailed information on arthritis, there is a separate programme in this healthcare series which describes the main types of arthritis and how to prevent and treat it. We're going to concentrate on problems that arise in the back as a result of outside influences, the effects of damage which can be brought on not only by direct and obvious injury, like a car accident or falling down the stairs, but also by repeated minor strains. Now, these, of course, we may be unaware of at the time, but they can add up over the years to serious and permanent damage to the back. We went to the biomechanics laboratory at University College Hospital Medical School to talk to Professor Donald Grieve about how the back can be damaged by everyday stresses and strains.
No two individuals are the same in their strength. You and I may have exactly the same height, we may be exactly the same weight. Nevertheless, that would not mean that your bones have the same intrinsic strength as my bones. And when we test individual bones of the back, we find a wide range of strengths. Therefore, you cannot generalize very easily about exactly what sort of task would cause an injury to the back. Now try pulling horizontally backwards, as if you were pulling something across the top of the cupboard.
To understand why the back is particularly at risk, we asked Professor Grieve to explain the anatomy of the spine.
The things I'd like to emphasize are the strength of the spine, what it's protecting, and how muscles act upon it in order to control the posture of the spine. So if we could turn to this model here, we have a series of bones which are referred to as vertebrae. These up here are in the neck. Then follows a succession of 12 vertebrae which belong to the chest. And finally, we come to 5 bigger bones which are belonging to the low back. You see that the bones steadily get larger as we proceed down towards the pelvis. At the top, only the head and neck has to be supported, and therefore the loading on those bones is much less than it would be at the pelvic end. As we come down through into the chest region, then the weight of the arms is added. And finally, when we come to the pelvis, we have added the weight of the trunk as well. And therefore, I think we could recognize an adaptation of the human back to the weights increasing towards the pelvis. What you can't see in this view of the model is the spinal cord which lies behind these bodies. But you can see the individual spinal nerves which are emerging from the spinal cord. One pair of nerves in between each two vertebrae. It's most important that whether the back is bent backwards, forwards, or sideways, that the spinal cord doesn't get kinked and that the nerves emerging through the holes in the sides do not get compressed or irritated. And therefore, there must not be excessive movement between any two adjacent bones. In fact, when we bend forward, the movement is distributed throughout the entire length of the back. Now, what allows adjacent bones to move is the joints which we find between them. What we see in between adjacent bones is a disc. It's called the intervertebral disc, and if we opened one, we would see in the middle of it a gel-like material, and that bubble of gel is held in place by a jacket around the outside which is fibrous. We're looking at the side of our model. Now imagine the posture we would be in as we bend forward to lift something. Our head is well forward and its weight acts here. The arms through the shoulder girdle have their weight acting here, and anything in our hands will also be acting there. Now, all those weights in front of the spine will cause the spine to collapse forward unless we tense muscles in our back, and at the same time, the bones of the back come under compression. So we have compression here and tension here, very much like the design of a crane for lifting weights. And it's under these conditions, especially in modern life, when the compression is either too great upon the bones and the discs, or the tension expected of the muscles becomes too great. And under those conditions, we get injury.
Paul, then it seems that the spine is particularly vulnerable to stress, and yet it seems strong and well designed.
Yeah, it does a pretty good job most of the time, although some of us feel that there are, well, perhaps one or two design faults in it. If you were an architect, for instance, you put the main structural support in the obvious place, right in the middle, like the trunk of a tree. Now, we evolved from four-legged animals, where the spine is rather like the ridge of a tent, supported by the legs with all the weight slung evenly under it. By standing up, our spine takes all the weight above it, thus more and more as you go down. And because it's placed at one side of us, at the back, the weight is pulling unevenly on the bones.
And the stresses and the strains?
Well, Professor Grieve talked about tension and compression. A man weighing, 12 stone or so, on bending or twisting his back, can exert a force on the bones which might exceed 25 or 30 stone in the equivalent weight.
Perhaps it's not surprising then that so many of us get bad backs. And it's also becoming clear that if we understand what's happening, then we can avoid the minor problems now and possibly the more serious trouble later, which presumably to many people will mean a slipped disc.
Yes, that's certainly one common end result of chronic or long-lasting back problems. Not that the disc actually slips. Remember that the spine is the only place in the body where there are these rubbery discs in the joints, allowing them to move, yet holding them apart to avoid compressing the nerves. Now, what happens is that repeated compression forces force the softer centre of the disc to burst through the outer layers and stick out like this. In these X-rays of people with slipped discs, a dye which shows up as white has been injected into the space around the spine. You can clearly see the disc bulging out, and this can have two effects. The bulging disc may directly compress a nearby nerve, or by narrowing the remaining disc between the vertebrae, it may cause the nerve to be squeezed by the bones, particularly on any movement. In either case, the effect is the same. The nerve, usually the sciatic or main nerve to the leg, becomes painful, and that pain is felt not only in the back, but down through the bottom, into the thigh, and sometimes all the way to the foot. Sciatica often follows episodes of recurring backache, and it may come on suddenly after lifting or awkwardly moving, but sometimes it comes on more gradually or out of the blue for no apparent reason at all.
But if you have sciatica, presumably you can get treatment for it.
Oh yes, it's important to stress that if you think you have sciatica, then you must see your family doctor. In the early stages, we treat sciatica with rest, and that really means complete rest. The first and most urgent thing to do is to lie down, flat, on a well-supported surface, perhaps on the floor, so that the shape of the back is normal and the weight is off the disc and off the joint.
And that's to relieve the pressure then on the nerve, is it?
Yes, and to allow the tear in the capture of the disc to heal. That may mean 2 weeks, sometimes more, flat on your back, with as little movement as possible.
And then I suppose you have to get going again rather slowly, do you?
Yes, being very careful to protect the back and not to do too much too early. Gentle, progressive exercises that strengthen the muscle and restore the posture are ideal. And getting back on your feet after an injury like this will often involve the local physiotherapy department.
We visited the physiotherapy department at Basingstoke Hospital, where senior physiotherapist Linda Tagg was running one of the department's regular back classes. These are designed to help people who've had physiotherapy treatment for back problems to take good care of their backs in future.
The principle behind physiotherapy for back pain is to try and relieve pain and improve function and get the patient back to a normal working life, or as near normal as we can get. So we're aiming to relieve pain, improve muscle strength, improve posture, improve range of movement, and educate them as to the sort of thing that they should and shouldn't be doing, how they should be doing it, in the hope that they can reduce the risk of getting a further problem in the future. Range of treatments available are electrical treatments such as ultrasound, pulse shortwave, interferential, manual treatments which include massage, manipulation and mobilisation, which is a gentler form of manipulation, exercises, and these can be either to increase range of a stiff back or strengthen up weak muscles, hydrotherapy, which of course is exercising in water, acupuncture, and hypnotherapy. Acupuncture has been used for some years in pain relief clinics in hospitals, and over the last 5-6 years it started to be used in physiotherapy departments, and there are now a lot more physiotherapists actually practicing acupuncture for the relief of pain. So it's becoming more commonly available, and it is a very effective form of treatment. We help more patients than we don't with those that we do see for acupuncture. Acupuncture can sometimes effect a cure, in inverted commas, because very often chronic pain sufferers have a build-up of chemicals within their nervous system, and acupuncture works on a chemical means which can reverse the chemical changes that are there and consequently get rid of pain. So they haven't really been cured as such because the cause of the pain had long since gone, but it was this pool of chemicals that was causing the pain. So in that sense, it can actually get rid of pain completely. The important areas of self-help are for the patient to learn about their back and about their own condition and try and cope with it themselves. And if they haven't got access to a back school or a physiotherapy department, something they can do is get hold of a good book which has got the basics written in it in very simple everyday language, so that they can learn from that the sort of thing that they can and can't do.
It certainly seems that physiotherapy nowadays offers a wide range of techniques to deal with pain and to improve mobility and posture. Paul?
It's not only in the recovery stage of a disc problem either. One of the traditional treatments provided by a physiotherapist is traction. If lying flat relieves the pressure on a damaged disc, then traction goes one stage further. You apply weights to both legs through pulleys to encourage the vertebrae to separate, the muscles to relax, and the space where the disc is to be restored.
So would you ask for traction then if the sciatica wasn't getting any better simply by resting?
Yes, if my patient's at home, then the journey to the hospital in the early stages might do more harm than the treatment would do good. So I would use it in recurrent or particularly slow cases. But if the disc problem is so acute that the patient's already in hospital, then the physiotherapist would probably use it straight away.
Now, if this doesn't work, when do you have to think about surgery to remove the damaged disc?
Well, surgery is one of the options. The great majority of people will have responded to rest and to physiotherapy. In the end, though, they're still left with a healed disc with a scar where it was torn. So they will have to be careful for quite a while, and sometimes a chronic relapsing sciatica follows on from an acute disc.
So is that when you'd need surgery?
I think the two main reasons for considering surgery are in the very severe acute case, where the disc is pressing on a nerve and it can't be relieved, and so it threatens to harm it, and the chronic repeated attack, where those x-rays we showed earlier reveal that the disc hasn't healed properly.
Well, we went to talk to Mr. John O'Brien, an orthopaedic surgeon, and asked him to explain the kinds of operation that can be performed on the back when disc injuries fail to heal.
There are many and varied surgical techniques available, assuming, of course, that the patient is disabled and has failed conservative treatment. Let's start with the surgical treatment that is most commonly represented in the lay press and in medical texts. If you look at this model here, you will see these are vertebral bodies connected by a disc. Behind the disc and behind the nerve root, you'll see here the small facet joint. Now, the first surgical procedure is so-called discectomy, and this is the most commonly known one. Take, for example, a severe injury to this disc. Its weakest fibers or thinnest fibers are at the back. Now, if there's a significant injury here, this part of the disc may tear. The inside of the inner core of the disc, so-called the nucleus, may migrate out through this tear from the heart of the disc so that the contents of the disc will push on this nerve root much as my finger is pushing there. This will produce an intense sciatic pain which will often not respond to conservative treatment, and the most rational operation for this is through the back to remove the fragment of disc which is pushing on the nerve root. Now, this only removes a few grams of the torn disc. It would depend on the size of the fragment, but you're talking about 4 or 5 grams as a fairly large fragment. So it's quite a small piece. The second basic type of operation is, again, because the disc is torn, but there is no part of the disc which is pushing on this nerve root. In other words, there's a tear within the disc. If this is identified as the source of pain, then the principle is to remove the pain source, remove the whole of the disc, as opposed to removing the fragment of the disc, which I just mentioned in the so-called discectomy operation. It's a frontal structure, so it makes sense that we take it out through the front, take the whole torn, sensitive disc out, and replace it with bone graft from the adjacent iliac crest or pelvic bone. There is a third broad type of operation. Bony spurs will grow and compress the nerve root and the contents of the spinal canal. If, again, conservative treatment has failed, then it is appropriate to do limited laminectomy or removal of these posterior parts and removal of the bony spurs to prevent this irritation of the nerve tissue by the excessive bone growth, which is really surgery we see more commonly in the older age group.
Surgery is then one of the options if bed rest and physiotherapy doesn't do the trick. There are several other possible treatments though, and as they're all different, you can try any or all of them. They all essentially involve pain relief, and many hospitals have now set up pain relief clinics specifically for people with long-standing and difficult back pain that needs rather more than common painkillers. Dr. Tim Nash is a consultant anaesthetist in charge of the pain clinic at Basingstoke Hospital. We join him as he's trying out one of these pain relief techniques.
The pain relief clinic is designed for the treatment of chronic pain problems, and most of the patients have been, if you like, through the mill. They've seen their general practitioner, they've seen other hospital specialists, and they still have their pain. They have been fully investigated, the condition has been diagnosed and treated as far as is possible. In some cases, the condition may have been cured, but they are still left with the pain. Others, of course, will still have the painful underlying condition and the pain. And these are the patients that we see. The purpose of the clinic is to look at other ways of treating the pain and to work alongside our other colleagues in other disciplines. So it is not just one doctor seeing the patient, it is a doctor hopefully deciding on a treatment plan for the patient and then pulling in appropriate people to help.
One technique that's commonly used for back pain in a pain relief clinic is transcutaneous electrical nerve stimulation, TENS for short.
Transcutaneous electrical nerve stimulation is one of the stimulation procedures we can use to dampen down the pain impulse as it travels along the nerves and up to the brain. It works possibly in a similar sort of way to acupuncture, and involves putting electrodes on the skin around the painful area. These are rubber electrodes stuck on and then attached by a lead to a very small battery box that is portable, can be worn on the belt, and the patient can switch on and off at will to produce a tingling sensation. This tingling sensation can then act to dampen down the pain impulse.
Yeah, no, yeah.
Is that quite strong?
Yeah.
Too strong?
No, it's all right.
That's fine. Good. I'm going to change the pulse now, so it's not such a slow beat, but more a continuous fine tingle there. All right? Tell me if it's uncomfortable at all.
Other techniques that are used to control pain involve injections of anaesthetic directly into the back. The commonest of these is an epidural.
Epidurals are injections that are commonly used by anaesthetists as a local anaesthetic technique for major surgery, well, for any form of surgery, in fact. And of course, many people will be aware of epidurals from having babies. So they are commonly performed in maternity units up and down the country. We use epidurals for sciatica. Sciatica particularly from an acute disc problem that has not settled with rest, and we are injecting local anaesthetic into the spine around the nerves and where the disc is, so that first of all we dampen down the pain for a short time, the muscles can relax, the pressure can be taken off the nerve root, and also within that mixture some hydrocortisone, some steroid, to settle down the inflammation and hopefully settle down the acute disc problem that they're suffering, so that they can get back to where they were before the pain started up. They may well have had that slip disc for years and not known about it. We put in a needle into the wrist or the arm, and most people find that's as bad a part of the procedure as any, just like having a blood test. The next stage is for me to go and wash my hands, get everything ready, and then curl the patient up into a tight ball. They're usually a bit fatter than this. And we don't put the head under the arm like that. This is just to try and show this off. And then a little pick in the skin overlying the back here, and inject the needle down into the bony canal here. And then we inject our solution into the bony canal here so that the fluid washes around the nerve root and the disc. The disc you can see here and is lying just in front of the nerve cord here with a nerve just in front of it here. And so if it slips, it can be pinching this nerve. About 2/3 of patients, actually 1 year later, are saying, "Thank you very much, I've been pain-free since the epidural." So the results are quite useful for this group of patients. low back pain can sometimes arise from the small joints in the back, and these are lying here and here in the spine, and the ligaments that are around these joints. The pain that can be produced by the facet joints or the ligaments there when there's a pull or a strain of a ligament is a low back pain, a chronic pain that is worse with any sustained posture, sustained sitting for any length of time, driving, standing, even lying in bed. It's a great relief to get up and walk about in the middle of the night. And this pain can sometimes respond very well to facet joint injections. The facet joints can be easily injected with the help of X-rays, and they lie here, on both sides, of course, down here as well. And of course they run all the way up the spine, various points all the way down the spine. And people can inject either directly into the joint with local anesthetic and hydrocortisone, or to the nerves supplying the joint, which run around the joint here. This is useful to do because we can actually permanently dull these nerves if we wish to by various techniques. Some patients will respond for 3 months at a time and can then have the injections repeated so that they continue to have injections 3 or 4 times a year, but are basically pain-free and coping with a basically normal life. Generally, though, we consider the injections to be a test to see if that is where the pain is coming from, because we can do more permanent injections to dull down the pain from this area.
Interesting techniques there, but it seems you have to keep going back for treatment.
I think it depends what they're used for. Many doctors will use one of those anaesthetic or cortisone injections when they're faced with a patient with a sharp but hopefully short-lived pain, the acute back. The real value of epidural injections or the transcutaneous stimulation is in the nasty long-term backaches. These occur after a disc is damaged, when you're waiting to see if it'll settle, or when there's still pain after surgery, or perhaps when surgery isn't even practical.
Now, are all of these techniques then used in addition to the more ordinary pain-killing drugs?
Yes, there are several different types of medication that may be useful. Painkillers, analgesics we call them, come in many kinds and different strengths, and they're commonly used in the acute backaches. But I think we're a little cautious about using some of them long-term, as they can lose their effectiveness. A lot depends upon the individual patient, and this is something that really needs to be discussed with your doctor.
But painkillers are not the only sort of drugs that are used in back pain. I mean, I know people who've been prescribed anti-inflammatory drugs, although there have been warnings about their use recently, haven't there?
The use of any drug requires careful thought. Any kind may have side effects, and you have to weigh the benefits from it against the risks. Anti-inflammatory drugs work by suppressing the inflammation around the injury. Now that relieves the pain, and it may, if it reduces the swelling and compression, help the sciatica. Some anti-inflammatory drugs are specifically designed for relatively long-term use, and many people have a lot of benefit from taking them. So again, discuss it with your doctor.
Are there any other types of drugs that are useful?
Well, those are the commonest kinds. Now there are others. Some people find that it helps to take a muscle relaxant. Much of the sharp pain in the back comes from muscular spasms as you tense up to try and protect the injury and prevent it from moving.
Aren't these muscle relaxants, though, the sort of drugs that you prescribe as tranquilizers?
Yes, some of them are similar, although I'd never use a tranquilizer as such in this situation. Long-term backache is a pretty miserable business, and in the past, sedatives and antidepressants have been tried. But wherever possible, it's better to treat the cause, not the effect.
At the same time, of course, if you get anxious about any problems or what may happen in the future, it can all make the pain worse and your recovery slower. In fact, it's quite remarkable how much we can influence our bodies and what happens to them simply by our mental attitude. Taking a psychological approach to pain, of course, is not to suggest that the pain is imaginary. Quite clearly, it's very real. But if the pain is in your back and your brain is in your head, then how much control can you exercise over the nerves in between? Well, Helen Jellicoe, who is clinical psychologist at St Thomas's Hospital, believes the answer is quite a lot.
I suppose the main aim, really, with trying to use psychology to help people with pain problems is to actually give them some hope again, to actually see that there is something that can be done. Because if you think that by the time they've had this pain for a long time and all the main experience they've had is of treatment failing. So the main aim is to actually help people see that there are things that can be done. So we would, first of all, try and establish what has happened with somebody, and then go through the sort of medical history, their understanding of what's happened, and then work gradually with them to actually see what they could do to help themselves, to get out of the trap.
Harry Davis was certainly trapped in his pain. Though he's now very active, he can clearly recall his 4 years of depression and disability after seriously injuring his back in an accident.
I was at home, I was depressed, irritable. There was times I reached a stage there where I know for a fact that if I'd had a gun in the house, I would have blown my brains out. I'd have ended it all. There was even times when I discussed with my wife. I'm only sorry, I said, that when the accident happened, that it didn't kill me. I said, because I can't stand this pain any longer.
After years of unsuccessful treatment, including surgery, Mr. Davis was referred to a pain management clinic to see a psychologist.
I resented it, and I told him so at St Thomas's Hospital. And I told him in no uncertain terms, so much so I said, I actually broke, I thought I was on the verge of a nervous breakdown at the time there. And my way of thinking wasn't all clear. And I became very distressed while I was there talking to him, whilst I was arguing with him. I broke down and cried, and I said, I resent being sent here to see a psychiatrist. I said, it's not in my head, the pain. I said, it's in my body.
I suppose once we're using psychology, we're not saying in any way that the pain is imagined, but what we're looking at primarily is how the person themselves is reacting to the pain, to actually see when it changes. So they would take home a diary and monitor the pain for a week. They would monitor whether it's affected by certain activities. They'd keep a diary of what they've been doing to see how that affects the pain. They would learn relaxation, and then it in turn would actually see how that affects the pain, whether they can relieve the pain with it, whether they can use the relaxation in their everyday life so that they can cope with situations better. They would look at how they respond to the pain emotionally, maybe seeing whether, if they get down in the dumps, whether the pain is worse and what they can do about that. We would teach people exercise. That would not be our role specifically, but we'd work alongside physiotherapists and teach people to do certain exercises, simple exercises within their capacity at the time, and they would then go away and practice them. So overall, by the end of the programme, you are aiming for the person to actually feel that at least they know the boundaries of the pain and they know what they can do to actually control it as best they can.
If you suddenly feel you're in pain, now instead of reaching for the pain-killing tablets, they teach you how to relax, and you can do it by standing up, you can do it by walking, you can do it by having a bath, anything like that there. But whilst you're doing it, you just sort of say, count, and just, you close your eyes, keep your eyes open, whatever you're doing. But you learn to relax, and you then feel that you're in control of the pain that's in your body, that it's not overriding you. And then the first thing that goes away is the panic.
I think the main thing that they learn, it's difficult to sum it up because everybody's very different, and I think that's the important thing, is that people are different and you have to really help people manage it in their own way. I think the main thing they take away is a sense of control. I use the word a lot, but it is, they find ways. First of all, they find out how they're reacting to it, and they find ways of coping with it better.
Before I went to the clinic, I had difficulty in walking any distance, 100 yards, 200 yards. After just 4 weeks in the clinic, I find now that I can get up and I can walk and jog anything between 4 to 6 miles. I would pay to go and speak to a psychologist. I would pay to go and see him. He'd put different ideas into my mind, and all thoughts of trying to do away with myself and that there, they would never enter my mind anymore. My attitude has changed completely.
Quite a remarkable story, Paul. How typical is that?
Well, I've certainly known many patients who've benefited from this sort of psychological management. It's the great advantage, of course, that it minimises the use of drugs. I think you've got to remain open-minded and say, for the right patient, it's certainly an option.
Well, Harry Davis had a lot of surgery, a lot of treatment, and he still had pain. How typical is that?
Once a disc is removed, it can't press on a nerve, so it can't cause pain. But if the nerve's already been damaged by the pressure, or perhaps other problems exist in the vertebrae, not all the pain will be relieved by the surgery. It's possible, too, that another disc could become affected.
Yes, I see the point. Of course, we're talking about a very small minority of people in that sort of situation, aren't we?
Oh yes, even slipped discs in total represent only a small proportion of the people with back pain. The majority of us, after all, with perhaps the chronic nagging backache or the repeated acute pains, have nothing really structurally wrong with our backs. These are the large group of what we call the functional disorders.
Still painful though, aren't they?
Yes.
But of course, these are the problems that we can all do something about. Now, for most of us, most of the time, the back performs very well in supporting us and allowing us to move. And like all supporting weight-bearing structures, it works best if it's straight. Well, almost straight.
Yes, in fact, the spine isn't really straight. For instance, here in the chest, where the ribs are, it bends outwards a little to give the chest its slight barrel shape, and this allows the breathing movements. So, above here in the neck, the spine turns upward again to allow us to hold our head level. Equally, below in here in the lumbar spine, it turns to join the pelvis, thus keeping the body weight even. So, in all, you have a sort of slight elongated S shape.
So when we talk about a straight back or a good posture, we should in fact be holding ourselves like that.
Yes.
Of course, problems arise because in everyday life it's difficult to maintain the back in the ideal position. The commonest crime is bending forward so that the spine's natural strength curves are lost. Soft beds and so-called comfortable sofas, car seats, and working positions that force us to bend the back out of its natural shape all produce postural problems that can lead to back pain. Fortunately, there is increasing interest in well-designed furniture that supports the back properly. And we visited a specialist shop to hear how the chair that you sit on can help maintain good posture. We asked the owner of the back shop, Benita Manaya, what's wrong with most furniture?
Well, the majority of modern furniture is built to please the eye of the designer rather than built to fit the human body. And that's what makes it wrong. It looks good, but it doesn't feel good. Soft settees presume you are going to slouch and sink into them, so you can't do anything but slouch and sink into them, neither of which is very comfortable. The design principles of the sort of chairs that we sell here are principles that work ergonomically. They work with the body, not against it. All the chairs we sell have forward sloping seats for the very specific reason that if you tilt the pelvis forward and you open up the angle between the pelvis and the thighs from 90 degrees to 135 degrees, you will relieve pressure on the spine. And by relieving pressure, you will allow the spine to float forwards without any difficulty. Now, you'll notice that the seat of the chair is particularly short.
Yes, why is that?
That's designed so that you don't have any pressure under your thighs. It's also designed so that you can open up your body angle. It doesn't restrict your movements.
As well as having a well-designed chair, it's also important that the height you work at a table or desk is the correct height for you.
Everybody is individual. People of the same height have different torsos and different leg lengths. So you must gauge your seated height to suit you personally. There is no such thing as a standard height person, so there should be no such thing as a standard height desk. This is quite a high desk, but it's easy to see that it's the right height for you. Now, the way to measure your desk height is by having your forearms parallel to the floor with the right angle at your elbow. If you can just rest your arms on the desk, it's the right height. It's okay to go up an inch or down an inch, but if you go up or down any higher or lower than that, you're going to be uncomfortable and you're going to put a lot of strain on your neck and shoulders. At the simplest level, you raise the table on blocks or use leg raisers. At a very more sophisticated level, you buy a height-adjustable table. Sadly, height-adjustable tables, although they do exist, don't go up high enough. If you have a working chair that has a flat seat and not much of a back support, you can use something like this, a piece of foam cut in wedge shape that will tilt you forward at an angle of 8 to 10 degrees and provide the necessary 135 degrees of open hip angle that we spoke about earlier. If you need to modify the back of your chair, you need nothing more complex or complicated than a simple lumbar roll. Put along the belt line, a lumbar roll will help to alleviate back pain by supporting the lumbar area of your spine.
Obviously, you can spend a lot of money on high-tech furniture, but of course you don't have to. You can use dining chairs instead of sofas, or a board under the mattress, and those foam wedges. Simple things like that may be all that's needed. Paul?
Yes, indeed. And how you use the furniture is important too. Not sitting or even driving in one position for too long without moving or stretching. When you sit anywhere, watch your posture with your back upright and your bottom well into the angle of the chair. Even when you're walking or standing, stretch your spine upwards and keep the back straight.
Now, all this is going to help prevent damage, which is caused by postural stresses. But what can we do if the damage is already done? I know some people who have back pain do try to correct their posture by sitting upright, but then they say they're even more uncomfortable.
It may just be that they've spent so long in the time in a bad posture that it now feels more natural and the muscles and the ligaments will need stretching again to improve. But it may also indicate that some more intensive work needs to be done to put things right.
Once the supporting muscles and ligaments have got used to a bad posture and have been stretched or contracted to fit it, this new shape may become quite normal for them. And then, because they're not being properly held in place, the small bones and joints of the back can move and cause even more distortion of the natural architecture of the back. This may be correctable by improving posture or by exercising, but this can be a slow and painful process. One way of speeding things up can be by manipulation, as osteopath Mr. Graham Mason explains.
From the time the osteopath starts his training to the end of the 4-year course, which he will cover, he will learn many techniques. Most of them very gentle, very soft, very caressing techniques. The one technique you always hear about, the one that gives the click and the crack or whatever, is just one of a multitude of techniques that osteopaths use. And in fact, we have a saying within the profession that force conceals weakness, and that is very true. You do not need force to be an osteopath. The most common presenting problem that osteopaths see from day to day are low back conditions, and these are low back conditions which are either associated with some form of nerve root pain, which gives a sort of sciatica or a toothache-like pain in the leg, or neck conditions, upper extremity problems, arms and legs. All these problems, either due to patients being manual workers and straining their back at work, or having long-term problems that are built up, for instance, with somebody who has been driving for 40,000 miles every year over a long period, suddenly develops chronic neck problems. It are those sort of conditions that osteopaths tend to treat mostly. If we can just bring your knees up together, just take you through a row of passive movements, which are, this is flexion, just feeling each joint in turn, right down here, right at the bottom, and then coming up to the one above it, L4, and L3, L2, and I'm feeling how they're moving under my, what is passive movement. We've just done your active movements, and we're just looking at that. When a person first comes to an osteopath, first thing he will do is take a case history. After that, he will examine the patient segment by segment spinally to see how that spine is working in that particular patient at that particular time. He uses a wide variety of manual skills and his highly tuned sense of touch, which has come over numerous years of training, a number of years of being in practice. And again, using that skill of touch and perception, he'll be able to devise what sort of treatment is necessary for the patient and perform that treatment. In 1986, the Which Report came out, and part of that Which Report on alternative medicine osteopathy stated that 90% of people who attended osteopaths for back pain, in fact, either effected some great improvement, or in their own words, and not ours, a cure. Osteopathy can afford the patient a system of treatment which will help alter the spinal mechanics. The average spine, during its working life, makes many changes, try to adapt to what we do, whether we're sitting in front of a VDU machine, whether doing heavy manual labouring or sitting in a motor car. A lot of the time, those adaptations are not good. They don't do it correctly, and that leads to problems that occur because there has been a mechanical breakdown. The osteopath can help remedy these mechanical breakdowns and bring that spine back into what is prime working condition for that patient.
Well, that explains osteopathy, but there are other kinds of manipulation, aren't there, Paul? What about chiropractic, for example? That's a form of manipulation.
Yes, it's less common. Osteopaths and chiropractors both use manipulation, though. Osteopaths tend to use softer and gentler techniques, including massage of the muscles and gradual stretching. Chiropractors are similar in their approach, but perhaps they favour more sudden thrusting manoeuvres.
So does it make any difference who you go and see?
I'm sure they'd have their preferences. I think honestly, though, that patients will get relief from either, and the techniques are fairly similar. You can certainly see some quite dramatic results from manipulation. These days you may well find some doctors who manipulate, and physiotherapists are doing it increasingly. At present, though, osteopaths and chiropractors can't provide treatment on the National Health Service, and doctors can't refer their patients to them directly. But manipulation in good hands is very safe and it's effective. You should always seek out a properly qualified practitioner, registered with their national organisation. Then you'll be getting an expert who will be able to tell you what can be done, and more importantly, what conditions manipulation won't help.
So any form of manipulation or massage needs follow-up with postural control and probably exercise as well. One method which is becoming increasingly popular is the Alexander technique. This is a very gentle kind of manipulation which concentrates on teaching good postural habits, and that's why the manipulator is called the teacher and the patient the pupil. We went to talk to the Alexander teacher, Glyn MacDonald.
When a person comes to an Alexander teacher and they come to you in pain, the first thing that we try to do with our hands is to re-establish the good use that they have forgotten for whatever reason. And we do this by re-establishing the balance of the head on the neck, on the spine. Now, the back pain can be for any number of reasons. Maybe they've had a whiplash car injury, maybe they've had a fall, maybe just through years of misuse at sitting at an office and typing, maybe they've always answered the telephone on a twist. All of these habitual misuses eventually will lead to a deterioration in the use of the back and the spine. So it's not just for accidents, but very much when the person has almost worn themselves out by their bad way of using themselves. And we will try and re-educate them through the gentle manipulation back into the good use. During an Alexander lesson, the Alexander teacher will gently guide you through a series of movements. One of the things that Alexander decided was very important was how we get in and out of a chair. For most of us, we don't think about this at all, but first of all, the teacher will put the hands on the head and neck and gently check that that is free, that the skull is freely poised on the end of the spine. Don't stiffen the neck, head to go forward and up, back to lengthen and widen, and in about 1 second I'm going to sit you down. So just allowing the spine to lengthen, to then say, no, I'm not going to sit yet. Now I'll sit. Bravo. That's it. Very good.
The Alexander technique also uses the same gentle manipulation in a lying position.
Neck to be free, back to lengthen, and widen. The advantage of getting the pupil to lie down is it does give them a moment to stop. When people rush in for their lesson, stand up and expect you to start teaching them, they're very often holding themselves up. They're trying to achieve some sort of postural stance, very often that they think you want. So if you get them to lie down, you can gently move the limbs, the arms, the legs, and get the head to lengthen along the spine without them being involved. Of course, by this I don't mean that they're not completely attentive. They are. Alexander is about extending the field of attention, not just lying there and relaxing and enjoying it.
That's the Alexander technique. Now, what do you think of the advantages of that, Paul?
I think its strength is that it teaches self-awareness, so that we notice the balance of our bodies and then we feel more comfortable in a good upright position than we would slouching about. It's, I suppose, the same sort of approach as yoga.
Yoga is more of an exercise approach, though.
Yes, we've mentioned exercise a few times in this programme. We've also talked about the ideal curve posture of the spine. Now, the spine, of course, has no posture of its own. It's held in position by the supporting tissues, and when it comes to movement, that, I suppose, particularly means the muscles. So, any exercise that strengthens those muscles and tones up the supporting structures is bound to keep the spine erect and protect it from insults of daily living.
Exercise must be the right sort, though, and having a strenuous job or doing a lot of physical work every day may help, but it may just as easily add up to the sort of insult that Paul's just mentioned. Hard physical work or anything involving lifting usually means flexion of the spine, that's bending forward, and certainly looking after children and a home seems to involve little else. So if this flexion is the problem, extension may be the answer. This is bending backwards, something we don't often do unless we're exercising. Exercise is good for us anyway, but a few minutes each day doing keep fit or yoga-type movements that stretch the spine and extend it can abolish some forms of postural backache. Sport can help a lot too, especially swimming. You've got to extend your back to breathe, and then being weightless in the water, you're unlikely to put any great strain on the spine. There are special exercise classes for back pain sufferers, and we went to take a look at one to find out what sort of exercise is especially beneficial for the back.
Shoulders apart, together. 95% of people with back problems can and should exercise, there's no doubt about it. But there are always the 5% who ought not to exercise. On the whole, I would like the students to check with their specialists or GPs or their osteopaths if they should exercise, because occasionally that shouldn't be done. And then it is not advisable to attend a class, because that could be more damaging than anything else. People with back problems get very, very rigid because they are frightened to move. Hence, the length of the muscles go short, they thicken, and then the problem gets even worse. Now, the exercises are specifically designed for mobility because there are 3 stages in fitness. One is endurance, strength, and mobility. Mobility is the most important one because it keeps you independent. If you can't move anymore, this is it. Now, the exercises are working very, very gently, but quite strongly in the same sense on the elongation of muscles. So, for example, if somebody who has severe back problems in the lumbar region and they drive or something, or in the neck, and they turn suddenly around, it can throw them into a spasm. Now, when they come to the exercise classes, and because we work on mobility quite a lot, and they turn around, the muscles are long enough in order to take that movement. Strength is very important too. For instance, the most important supportive muscle group are the abdominal muscle groups, because if you have a weak stomach, it alters your posture. You start to have a bad posture. So if one works a lot on the stomach, the awareness of the abdominal muscle group, how much they influence the posture, you then give also the student a guideline when they don't exercise, how they can actually hold themselves. And if they start getting twinges in their backs, that actually supporting with the abdominals can help overcome the twinges before something worse happens. The exercises really do work. I have become a back pain sufferer, and during this bad time, during this acute attack, I used them purposely, and they really worked. Having been a dancer, and my standard for fitness is very high, or was very high, you weren't quite aware what the exercises, the gentleness of the exercise, how beneficial they could be. But now, the value of the gentleness, but they're quite strong in a sense. They really work wonderfully. For instance, when you have an acute attack, simple things become a handicap, i.e., how to comb your hair, how to put your shoes on or your stockings on. All this becomes very dramatic. So with the exercises I'm teaching, they are actually helping you to use individual muscle groups to perform a certain movement. Yes, I have to say they do work.
Paul, how important is it that you do exercises specifically designed for your back problem?
Well, most exercise programs deal with posture and extension, but also with the other movements of the spine, flexion, forwards and sideways, and rotation. Many people with mild or recurrent back pain will do 10 minutes of extension exercises every morning, and this is enough for them to be completely cured. There are exercises from a Keep Fit program, or you can get a backache leaflet from your own doctor. I think a useful tip is that you may find warming your back before you start with a hot water bottle, a heat lamp, or perhaps a warming ointment is especially a help, in the early days in particular. But if you don't feel confident, or if you feel that you've got a more serious back problem, then please seek advice first, particularly if you know that exercise makes your back worse.
Well, we can't possibly cover everything in a programme like this, and we're nearly at the end.
I hope that what we have done is to suggest a selection of helpful items to correct some of the problems of functional back pain, and to help avoid it becoming worse or progressive. If you've had a disc problem, then I hope that section's been useful too. And finally, if you feel concerned about your back problem, do talk to your doctor about it.
In many areas, self-help groups have been formed for people with difficult back problems. Your doctor, the public library or the Citizens Advice Bureau may well have a register of these or other sources of help in your area, and we'll show you a list of useful addresses in just a moment. But now, from Dr. Paul Stillman and from myself, goodbye.
Goodbye.